My name is Sutapa Agrawal. I am a PhD in demography and public health specialist. So and working with a lot of with data sets from the last 10 years, specifically the data which is available on the public domain. Okay, so big data sets which are available in the public domain, specifically on health, nutrition, and other socioeconomic aspects of the population in India and other developing settings. So, since morning, we are all listening to this very interesting thing on food programs and food policies in India, and yeah, those are all level social level policies, and whatever has come out from this floor, that yeah, very less evidence is available actually on these issues, and it's all on the policy level. Government is working, but we do have some little ways evidences. So I will be talking on some of the evidences from the data sets which we are getting on the population about food and nutrition, and how this is happening as a paradox. Actually, since morning we are listening about this is a paradoxical situation in India about food nutrition security, and on the one hand India has a lot of green revolution, there are a lot of food sufficiency, again still the kids and the population are still in the very malnourished and other stages. So let us discuss. It will be very interactive. Wherever you are having any concern and all, you can stop and just ask, or we can take out the later. And we will be discussing. I will be discussing mainly on the nutritional paradox in India, specifically giving examples from two data sets. So I will be discussing on those data sets as well. One is National Family Health Survey 5, and another is a very I will not say it is a new, but it's a type of data sets which has been done for in India for one of the first time. It is called CNNS. It's called the Comprehensive National Nutrition Survey. So it has been done by Ministry of Health and Family Welfare and supported by UNICEF. So just a little bit of introduction why it is why it is data is actually it's not just a number, and it always says some gives some evidence on the achievements and challenges, because there is a data, and data is where we have achieved, where we have reached, that can be said actually with the base of data. And what we miss actually, that is a really it's a type of that we should be very much do mind boggling, that we have in Hindi we call it as a chinta, but actually chinta ke wajah we can have a very much chintan, that's we can have a deliberation that why it is missed and why it is not done. And now on the different food programs and different programming we have in India. So survey data we have already, what the we get the data, it is from the survey, and also with the different program policies data, and while the different qualitative investigations we have, these gives the learning about the thing in the insights, where how to ensure they don't miss on a continuation basis, and especially for the poor and marginalized population, because for the overall population we have the program, but how, where is the missing link is there for the poor and marginalized population and the high risk households, where both all these things all these population exist. And also that nutrition issues are as we all have discussed in the morning, they are different than the health issues. Health is a different issues, but those are very much linked together, and we are actually very much missing on this nutrition part. We are all healthy and all, but where is the nutrition going? So what is the nutrition and what is the issues? And there is no booster dose for the nutrition, so we don't have vaccination for nutrition. It's all coming with the good health, and a good health and food, that is a nutrition thing. So there is nothing, we don't have any vaccination immunization program for the nutrition issues. So any nutrition issues might be undernutrition, overnutrition, or anemia, micronutrient deficiency, NCDs. These are all linked to these nutrition issues. And most nutritional paradox happen due to compromised. It starts from the mother's womb, and in the mother is adolescent women, and so that's a mother who start becoming mother, and there's a poor maternal diet and poor IYCF practices among the children. So that's the thing, it happens. And as I have told, is unlike health intervention, we need to focus on the various awareness program which is available, and which, and this, the health and nutrition should be imbibed in our behavior, everyday behavior. So it's not that aaj health ke liye we are working and today for the nutrition. No, it's with agriculture, with health, with nutrition, it should be a daily practice for everyone. So that's the one issues we have. So just giving a brief account of what are the various data sets available, and where in which data sets we will have the nutrition and health of the population, where we can get the data from there. Census, it is there, it is a big survey where we have all the socioeconomic factors, but we don't have anything related to health or nutrition or anything. But it is a big, it's a census, a big population. Another thing, we have DHS, it is a demographic health survey, which it is conducted by the USAID, and it's conducted in various countries, more than 80 countries it's covered in DHS. And India, it is called the National Family Health Survey. And till now we have 5 rounds of National Family Health Survey, always occurred at interval of 5 years, and it started from 1992. So in National Family Health Surveys, we have it is about the family health. So it encompasses, the main target is the women and children. Okay, they are the more respondent, and with the giving the basic of women and children, the survey asks everything about a women and child, starting from their birth to till their the mortality data is not there, but till fertility, the period of women is 15 to 49, till they are in the reproductive period, whatever happens, the survey covers. And in the reproductive period, the children are always there. So 0 to 5, and that children is covered in the very detailed analysis of detailed question about 0 to 5 years of children is covered in National Family Health Survey. Until now, it is one of the best data source for government in India, in any other countries also. This is a most important data source, where we have a lot of comprehensive data on the women and children, uh, where we can at least have some policy level discussions about the data, because it is a uh, it is for the it can be generalized, because it is for the whole population all over India is covered in this database. Okay, 30 states and other union territories, and but it is a sample survey anyway. So sample survey, they have has their own pros and cons, but it is a sample survey. But we can at least say that, okay, in India this percentage of population is having this problem, because it is said by the National Family Health Survey, and it's a big number of sample is there. So that is the thing. Another is data is there. I will discuss more about this afterwards. There is a LASI data and WHO SAGE, where it is covered the old population. Morning it was somebody was saying about the where is the older population covered. We don't have data on them. These LASI and WHO says they have some data, but it's not everything is covered in that, and it is not also comparable. Yeah, so they are also not covered in a regular basis. In some, it's not in all over India, but it's some states are covered based on their any sampling strategy they have followed based on some criteria, and some states are covered. So it's not that we can't generalize, but here the elderly population is covered in this data. So 18 to 30, then again above, then more than 60 to more than 60 plus population is covered in LASI and WHO SAGE. Then we have data set called CNNS, which I will be discussing more about this one. And we have also data set on young lives. Again, I have said that these are not very, it's not for all over India. Some 2 or 3 states are covered in young lives. Another is a big data set, it's called NSSO. Anybody has heard about NSSO? Yeah, so it's National Sample Survey Organization. They have data sets, but again it is not a public health data set. They have some of the indicators are about any health issues. Some consumption data is there, But again, last 1 month, how much you have consumed, that's a very vague type of question, but still it is there. It's good, better than nothing is there. It's one of the good thing it is there. And if anyone can analyze, mostly on the economic thing, the people used to work on this data set. Then another NNMB, Madam Deepa is told about the NNMB data that has been stopped again. It was only for some states, and it was a really dietary type of survey was there. It's the social issues were not covered much. You can't link the data with the social structure. The only okay ये खाना खाया बस खाया तो क्या हुआ है ना, it's on that part only. So, and again, it has been stopped now. The institution has been reloaded. Yeah. And this SRS, we have SRS, it is a periodic survey by the census department. And again, it is only data on mortality, and very little data on infant mortality and other issues, but not on any health issues. Yeah. So these are the most of the, you all can add if you know any other data sets which you can. These data sets are mostly in the public domain. Yeah, you can either you can give a request to access the database. Otherwise, it's mostly in the public. The National Family Health Survey, it is totally in the public domain. You can access anytime. But other data sets, it's with a request, and they will scrutinize whatever want to work with this data set. Then they will tell you you can use it or not use it. Yep, that's the thing. So, it is also useful to know what are the different data gaps or for the different population actually. So, I think it's a very busy slide, but you can just get a glimpse. If we want to concentrate on the children, so once the children are adults, the intervention period is over. Now it has been found out all the intervention period should start from the womb. Yeah, womb and till the children is getting adolescent, all the program should concentrate. But if we don't have a comparable data, whom to go and intervene? So we have a various types of data, and there are some certain indicators such as I have taken some certain indicators which are important for a healthy human being. So such as anthropometry. What is anthropometry? We have the BMI, we have the waist hip ratio, where all the healthy parameters can be measured. So these type of data where it is we can found most of the, see, I have compared 4 data set. It is NFHS, then AHS, it's the annual health survey. There is a DLHS. Earlier it was a DLHS, district level household survey. It has been from NFHS, National Family Health Survey. Third, it has been merged with the National Family Health Survey, the DLHS, and then NNMB data. So different age groups, considering different age groups, such as 0 to 4 years, then 5 to 14 years, and 15 to 19 years. So 0 to 19 years of children and adolescent. How different nutritional indicators has been included in the various Indian surveys. So see, you can see for 0 to 4 years, most of the surveys have covered. Yeah, you can see these are all blue colors, and no data is only for the some of the anemia data is not was available. But the very important period of life, 5 to 14 years, adolescent, most of the surveys have not collected any data. Yeah. So many of the most of the surveys, see some of the anthropometry is missing from this type of data set. Body composition, anemia, nutrient status, though never it was collected earlier. And again, physical education, physical fitness, and anthropometry, and that physical activity, it was not there. Again, some data was there for 15 to 19. So how it was there? Because National Family Health Survey, they have started collecting data from 15 to 49 age group people. So anyhow, the 15 to 19 age group of the adolescent is coming under that purview. Otherwise, WOBI they could have removed. Yeah. And again, most of the surveys have a male or female. That is also another issues. Not all male are covered, not all female are covered, like this. So here, most of the, for the children, is specifically that it is children, so male female children are covered now here. So I will be talking mostly on the 0 to 19 age group, this important age group, how the data sets are available or not, and how the different indicators of health and nutrition are spread over in different surveys, how can we conclude that what to do for with this population, and how to intervene, and how to help with the nutrition paradox. So this is a there. So 15 to 19, some data is there. 0 to 4, most of the data is there. But 5 to 14 years of age group, the 10 years age group, is totally missing from the different surveys which has been conducted in India. So in that way, the paradox has been situated. So now, coming to the comprehensive national nutrition survey. So I will just give a little background. The national comprehensive national nutrition survey that has been conducted during 2016 and 18, and it has covered all 30 states of India. It is a cross-sectional design household survey, as similar as National Family Health Survey. The data is there, and it has covered more than 2,000 primary sampling units, and it covered 82% of India's district. And the sampling frame was taken from the census 2011, which was the last census conducted in India. From that point of view, so this is a about the national comprehensive national nutrition survey. Shortly we call it CNNS. So why it is important to know the data for the to have data for the children and adolescent. So children, this is the first survey which has covered the micronutrient deficiencies of the children. Yeah. And so by micronutrient deficiency, we all mean that it is iron deficiency, vitamin deficiency, how it is. So how they have been collected. So there is a biomarker survey was there. So all the kids and children and adolescents, they have been biomarked. They have been, the blood and stool has been examined, and urine samples has been collected from that population. So this is a so these are there's a number, how big it is, just to show the number how big the survey was. And it is what type of children they are covered. There's a preschool children, school age children, early adolescent children, and adolescent children, both have been covered. And detailed nutrition on it has been provided on the triple burden of malnutrition in India, and the biomarkers indicating the micronutrient status, and assessment of the multifactorial causes of anemia was also there. There was also important that this data has a cognitive development index, so the reading skill and everything for a 5 to 14 years old children, how this thing can help in the program and policy. But unfortunately, so I will talk about it later, how the data has been now released by the government, and how what part of data you can use and what part of data you can't use, that is also there, because of the obvious reason which we has been discussed in the morning. So that's the thing is there. So, what were the different outcomes of the comprehensive national nutrition survey? So, this actually these serve as a baseline from the for the Poshan Abhiyan, which started by the government, and for the Anemia Mukt Bharat program, ANB program, which has been started with the Poshan Abhiyan program, and also it will help with the greater understanding of the anemia in India, which is still in after and National Family Health Survey 5 data, it is still that the anemia is prevalent is still so much higher among the women and children. So what's happening, what paradox is happening in the anemia, and that anemia burden is also a big question for this thing. And also data is to support policy on IFL, iron and folic acid consumption among the women, then vitamin A, B12, zinc and salt iodization. Yeah, and this is a new data. So we have only earlier we have only one data called NFHS, which used to give some data on 0 to 5 children. Now, so now this is a additional data. Now we can have a total biomarker data with the 0 to 19 age population, which is scattering these data. So I will tell you how to access this database and how to work with this database afterwards. So what is the nutrition paradox in India specifically is, I will give some of the indicators, and we can just have what is the state-wise and what is different sector-wise their prevalence in India. So just giving an example, Madam Deepa, this morning we have talked about under this thing, stunting and underweight. So how it is prevalent among the kids, and how it is affecting the nutrition situation of the population. So this is a situation. See, the both the wasting, stunting, and underweight, this is the highest indicator of malnutrition among the children. Both, all, everything, this is for the Indian children, and both it is for both male and female. These are all very, 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 very sketchy. Yeah. So see, you can see the lines is not good at all. Wasting, stunting, and underweight. After all, so much nutrition program is going on. Still, this is a situation in 2019. Just 5 years back, this was a situation in India. Yeah, I will just quickly go through the different, huh? And the time period from 5 to 9 years for the adolescent, just the early adolescent period of the kids. That is also does not provide the opportunity to catch up the growth in the stunting. Still, in that, how it is the moderately stunted and severely stunted, I'm just going into little detail. So it is that the almost one quarter of the children is 5 to 9 years were stunted. Still in 2000, just 5 years back, and till then we don't have any other surveys have not started. Maybe with all this program is something little improvement can be seen, but still now this is a situation. So significant proportion of children who are stunted in childhood remain stunted into their adulthood in the schooling period also. So this is data for the 5 to 9 years. Already we have seen this is the prevalence. This is earlier. This is for the 0 to 5 years period. Okay, 0 to 60 months period. This is the data. And now when they are growing up, that is 5 to 9. How still that is continuing? That data, that stunting is still continuing. है ना? So that will affect their potential capacity for education. How the multi-sectoral thing is continuing in the different periods. That's it. And again, 10 to 19 years, same thing is happening. So once a malnourished child, if you are not taking care of that, if you are not improving that, it is going on to the adolescent period. And again, in adolescent period, the girls are getting married again. So that thing again is passing to the generation. है ना? Thinness among adolescent. What is thinness? It is BMI less than 17. Yeah, thinness among adolescent is 20% or higher in the majority of the states. So this is a state-wise distribution. Yeah, India is in the backs. You can see what is the average and how bad is the other states and how good is the more than average. Okay, from Maharashtra to Madhya Pradesh, they are little bit they are totally, see, the northeastern states are doing good, but after that they are not. For the children to benefit from their last growth spurt, means the from 0 to 10 years growth spurt before adulthood, they need to be well nourished. That's why the reason they need to be well nourished. And this is especially important for young women who are going to be again mothers, huh? At the average of India's women average age of marriage is almost 20 years. Yeah, so that's going on in this thing. Then again, this is a overweight and obesity, as again the similar thing is happening with the overweight and obesity thing. Yeah, and see, from India, still it is not higher now, and but it's India overweight and obesity is catching up with the developed countries as well. Nutrition and health intervention in early childhood thus provide opportunities for improved population health and well-being if we have the correct nutrition intervention in the morning. But for that, we really need to have the data set. See which data we should take and which data should tell us all these stories. And this is quickly about the anemia prevalence. The whole of for 1 to 4 years of children, the whole of central India is totally red. It's a highly anemic state. Yeah, 5 to 9. Still, it is not much good in the others adolescent age as well. So, what is micronutrient deficiency? Actually, it is a type of hidden hunger. So, you are not taking good food, and so we are just taking the food, yeah, through the PDS, whatever the programs we are having. So, and we are not having the good food. So, if we are not good food and nutritious food, this micronutrient deficiency sets in. Yeah, so that is called a hidden hunger. So our stomach is full, but we are not nourished. That's the thing happening with the rich population as well. So something, well, quintal we are talking, that is a deficiencies is, has set in actually. We are eating food that is lack of vitamin, we are eating food that is lack of vitamin B, lack of folate, iron. So we are having our, it's, yeah, we are fine, we are getting strong, but where is the growth? So that is showing in the stunting and wasting thing as well. Yeah. So this vitamin A deficiency was 18% in children from 1 to 4 years in the, with the state-wise variation which this CNNS data shows. Vitamin B12 deficiency is there, is so much, is almost one third of the population 1 to 9 years of having the vitamin B12 deficiency. Then folate deficiency, zinc deficiency. You can remember that in young age doctor used to give zinc, folate. Whenever you fall sick, doctor used to put that zinc supplement. So that was a deficiency because we are not having through our food. We are supposed to have zinc thing from our food only, but we are not having. So that zinc supplement has an iron supplement, zinc supplement is started by the government during, because to tackle this deficiency. And vitamin D deficiency now, I think most year everyone will be knowing about vitamin D deficiency. Whenever you go to doctor, they say, okay, well, vitamin D deficiency, you should have this sun, and you should have some tablet. They were giving that weekly doses, but it's already, we have already set in during when we were younger age. Yeah. And best, and apart from this, we have a growing threat of NCDs, which is coming up among the kids, having the pre-diabetic stage and the different uh, this HbA1c. This survey has got data with the biomarkers, so we can say that these are the, and it is can be generalized. And the 10% of children and adolescent are having this HbA1c. The last 3 months sugar level, we can say that they can be tell us a pre-diabetic for these children and adolescent. We had taken the blood sample from the last 3 months, that's HbA1c measurement. So in that period, in that, with that data, the result is that 10% of the children can be say that they are the pre-diabetic stage. Yeah. And also it's very alarming that 7% of the children, means 0 to 19 years of kids and adolescent, they are having as big as a chronic kidney disease problem they are having. And they are clustered in few northeastern states as well. Yeah. And we are supposed to know that northeastern states are good, they are very eating nutritious food because they are very matrilineal society. So how come is all is happening? This, here is good thing is happening, but still the children are not good. Here bad thing, the central India is bad in everything, but still they are at par with the other state also in that, the in that category also. Okay, stunting here is 1.2 in Bihar, then again in Meghalaya it is also 1.4. So what is the difference? How difference can be then minimized? This is a different state, this is a different state, they have their different socioeconomic, they different, but the kids, everything is happening in the same, they are at par. Stunting is prevalent even in the higher, in the rich people, and stunting is even in the Bihar, in the lowest Bimaru states also as well. So that is a very paradox in India, um, which I don't know, this is my view. It's not a, it is, there is no, I think no government can, it's a need to have a very deliberation meetings and meetings and the very thing. But possible reasons, we can have, everyone can have a possible reason for that. Start from the poor adolescent and maternal nutrition, everyone can accept that, no? Because we have not done, our mothers were not fit, they were not healthy, we are having this thing. So that's the mother child relation is starting up, and based on that, है ना? So majority is not having healthy babies. So early marriage, pregnancy, too early, too soon, inadequate gap between the two kids, and too many inadequate diet during the pregnancy, and pregnancy weight gain. Both are there. Inadequate diet during pregnancy is also there, and pregnancy weight gain is also there. We are feeding the women that time with lots of things because okay, you should have. But that is also not helping. Pregnancy treated as a normal actually, and food for women is kept for at the last, you know. So if a woman is pregnant, there's the special treatment or a very good treatment is not that much provided. So as cultural practices, they are also seen to have lastly they have to shoot with. So these result in the low birth weight women, low birth weight babies. Yeah, one third of the babies are vesting, and one fifth of the children, means 5 to 15 years old. And again, poor IYCF practices. I'm sure everybody is aware of IYCF, that Anganwadi Center, the food program is going giving through program started by the government in 1974. So poor IYCA practices and young this thing, that so less nutrition, and so less poor the brain development also hampers. Yeah, with that thing it is so poor initiation of breastfeeding, poor exclusive breastfeeding still months, so the entitlement and all which we had discussed in the morning. So minimum adequate diet is still very very less in India. It's only 10 to 20% of the children between 0 to 5 years, they are having the minimum adequate diet, which should be at least more than 50%, but we are having in the still 10-20%. And it's all over the wealth quintile. It's not only in the poor or in the rich. It's spread over all. It's the all India average. 23% of the children, this is I'm talking about CNNS data, but National Family Health Survey also shows us that 20% of the kids are having the minimum acceptable diet. And this is very very alarming and poor situation. So poor children and adolescent diet also multiple micronutrient deficiency, which is a hidden hunger. Yeah. And again, burden with that junk food is all over available. So the rural India is still now NCD hub now becoming, because the food and all junk food and all are available. The Swiggy is delivering in very peri-urban areas, rural Indias. They are getting all food from there. So it's there. So people are not sugar and BP. Everybody knows in the I have sugar, I have BP. They knows I have to take that one goli. I will take. It's fine, but they are having that. Yeah. So how till recently how many have you heard that somebody has died of a communicable disease? Very less. No, I think it is not heard now. Okay, somebody is have died of diarrhea or some, and I'm not talking about COVID. Yeah, that is a separate issue altogether. But I am sure every household has a population who has died of NCD. Yes, any of your immediate relative, immediate family member has died of a NCD. Yeah, so now NCD has penetrated so much inside. It's the rural urban boundary has left now. Yeah, if somebody has BP, it's now generational. Your parents are having it is then you're bound to have some of the other till you are not changing your lifestyle. But still lifestyle changing is also not helping in that way. Yeah, highly gym going people are there also dying of cardiac arrest and everything. But it's not that you should stop exercising. It's not that. I'm not not doing telling that, but I'm telling that the NCD paradox, the the health paradox is such a thing now. We are not having, there is not one solution actually, or it's not, it's very individually. So what is working for you may not working for her. It's also that doctors are also very confused. Some think that okay, you can do whatever you, if you are is suiting you, you can take. I'm not telling, but this is the thing, you should take this one. That's happening. I think everybody can recognize that. And it's the rural urban differentials and the rich state poor state differences is not gone now. It's all now under one cover. NCDs are happening, non-nutritious food, everybody is happening. Yeah. So I will not go detail in this one. So poor minimum adequate diet among children is a gateway of nutrition paradox mainly. Here you can see Meghalaya. See, so they have the highest minimum. This 24% of the population in Meghalaya have the minimum adequate. The children 6 to 23 months, they have the minimum adequate diet. Good, but lowest was in Rajasthan. See, Rajasthan and Gujarat, they have the lowest population, lowest percentage of people. Why? But Rajasthan is a very highly economically advanced state. Gujarat is a very economically advanced state. Why the kids have Very poor percentage of women have given the minimum adequate diet. What is the reason? Nobody knows. Huh? See, the northeastern state, maybe that's the reason. This thing can be talked about. Whatever the we have the morning, we have debate on the vegetarian and non-vegetarian food. Might be. We don't know. These are basically the lower states are mostly the vegetarian state declared. They are declared vegetarian state. Yeah, maybe occasionally they are non-vegetarian eaters, but the higher states, see, Meghalaya, Sikkim, I don't know about Pondicherry, Jammu Kashmir, they are all daily daily protein eater states. I'm not talking about non-vegetarian, but maybe they are taking high protein diets. It might be. So see, the whole of India is totally red for this minimum acceptable diet for kids. For the children, we are having this type of lethargy that we are not about to provide there a minimum acceptable diet provided by WHO. So how can we help with the men and women in the adult? How can we deal with the adult? The kids are the most loved and most caregiving person we are dealing with. So if we are not able to provide the kids with this minimum, most bare minimum, nowadays we have only one or two kids, still we are not able to give them that nutrition. How can we talk about the adult men and women? That's the issue. Deepa ma'am, morning they have shown the different food group consumption. What is the difference here? You can see this is about the state wise differences. Yeah. So what is the, we have taken four types of food. Flesh food. What is flesh food? Fish and chicken, or flesh one. See where it is higher, 2 to 4 years. Again, Meghalaya, Kerala, yeah, Manipur, all they have the protein eater state. They have 24 hours. They have taken 2 to 4 years. Then where it is higher, vitamin A rich food. Again, Meghalaya, Sikkim, Mizoram, a very uh, pumpkin eating and another, and egg again, same state, higher. जहाँ ज़्यादा खाएगा वहाँ ज़्यादा फायदा मिलेगा, है ना? Other fruits and vegetables. Kerala high, है ना? Punjab is fine. Punjab eats other things also. They eat milk curd more, है ना? And then Meghalaya, Sikkim, those are the fits. So this is a situation. Indian kids 2 to 4 years, what type of food groups they eat. This is across the states. Yeah. And similarly, that was for 2 to 4 years. Now again, this is for 5 to 9 years. The very growing children. 5 to 9 years is a high growth spurt. No, that is a pansu 5 to 9 years of children. See how what is the situation there? Fish, it's a little changed now. It is a little changed. You will not find the same type of state. So where is the 2 to 4 years focus states are different, and 5 to 9 years focus states are different. See, Kerala, fish eating, flesh food, you can say. And then egg eating, Tamil Nadu is higher. And Andhra Pradesh, Tamil Nadu, Telangana, they are higher in egg eating. 5 to 9. And green leafy vegetables, Maharashtra, Karnataka, Orissa. And fruits, what is the situation of fruits actually? See, none of the states came up high, where they eat these things. Which states came here? NCT of Delhi, because it is available here. No, availability is also there, and affordable here. Affordability and availability is there for the fruits and fruits specifically. For other things, they are very local. Fish, if we are sitting in a pond nearby sea and all, you can have. But fruits, it has to be. It's not grown very locally. Yeah. Except for the states which are the very fruit growing states, but it's very affordable. Affordability is very important for the fruit eating. Yeah, so that is a very difference. Again, the similar thing, I'm not talking much, but this 10 to 19 years old, very highly active adolescent kids, adolescent children, this is a situation again. Again, egg eating, green leafy has the dimension has changed. Now goa is coming up in fish eating. See how the different age groups are behaving in a different way in their eating behavior. है ना? For 2 to 4 years the family matters much, because whatever the women, the mother will feed him, he will eat. Then 5 to 9, his own behavior comes a little bit. Oh, I will not eat this one, so he will not eat. So you have to buy the things for him. But and 10 to 19 years, it's family plus outside environment, the college wing, the school going, the highly active population. They are having their own behavior now, food eating behavior. So here the different states have changed. Yeah. So see again, fruits may NCT of Delhi has come up, and then Maharashtra green leafy. So I'm just wanting to say that in the different age group also, the different behavior of the population also matters with their eating behavior actually, and also affordability and availability. That is so there. So given this all the things, so what type of food is actually missing from the plate? What healthy food is missing from the food plate even weekly? Yeah, egg. A 62% of the population are missing egg every day. Not population 0 to 19 population. I'm just talking about this population, only the highly active and growing population. Fish, chicken, meat also is not there. है ना? Milk, leafy vegetable is so 3 out of 5 girls and boys did not have fruit, green vegetables and eggs even once in last week. So we have asked question last week how much it thing. So it's a high number. 3 out of girl among the 5 girls, 3 have not eaten anything. Yeah, and more girls missed milk. That is also an important finding. More girls missed milk. And what unhealthy foods are consumed at least 3 times a week? Just opposite of that, fried foods. It can be any type of fried foods, starting from kurkure or maybe ghar mein kuch and any other fried food also. But they are having samosa and any other fritteries, है ना? So that's the thing. So here the main nutritious food is missing, and then here extra junk food and fried foods are adding up. So you are putting one in, then out is also, all are combining together. So that's happening here, huh? And this is another important activity of physical activity. So this data did give the physical activity data, but the other data set, National Family Health Survey, does not have the this physical activity data. So it is here. See screen time, how much it is a screen time for girls? Girls spend 30 minutes, 45 minutes. Screen time is increasing, outdoor activities decreases with the age in girls, which has been obvious. So, no? Girls, they are growing up, then screen time increases and outdoor activities decreases. Very interesting to see. We all experience in our home also, no? In our family, we can say, oh, you are not going out when the kids are good. But see, it's the data is showing that. You know, physical activity is also decreasing. Very simple, just a cross tabulation data can give you such important numbers. And for things, for having a policy level discussion, we don't need a modeling. We can have just showing the simple percentages will help to see this is the situation actually. Yeah, model may give you a very very precise estimate, but if it is 5.6 percentage, it will be 5.3 maybe when we do a modeling. Otherwise the data will not change that much if the indicator and the topic is important. So how those things are then related to learning and education among the children and kids? So are they ready for a resilient future learning? So this is a very simple example of average performance of students is starting. It's from the national report. It's not from the this data set because we don't have data set for this one. So over the class, average math score goes down from 61% in class 3 to 51%. I think some of the recent times the data set that these findings have been shown up in the media also. So that is a thing. So the learning ability has been becoming decreasing. Maybe I don't know, maybe the screen time or any other things have come up, but this is situation now. Yeah. So given so much facts that these are the data showing that so much paradox is happening, so government has started, really the 2 3 programs are important. The Poshan Avian, it is a district wise program to cater to the different nutrition thing for the mother and the kids. So it should actually tackle the triple burden of malnutrition. Yeah. And which the data shows. And as we have seen, the control of the NCD programs must start in the early ages. 2 to 4, the 0 to 6 to 23 ages, starting with the minimum acceptable diet. If we can't provide a kid with a minimum acceptable diet, and how can we start with their help in their and other health issues? Yeah. So testing, counseling, treatment, both things should be at par with the different health centers, and it should be readily available. Testing, then test ke baad there is a problem, counsel, then if there is also a problem, then do the treatment and solve it. Like this, it's just a thing. And hidden hunger is very important. Micronutrient deficiency is a real nutrition thing. The real nutrition program, not the health issues, but the real nutrition program can be tackled with the addressing to the micronutrient deficiencies. That can be catered by diversifying the diets for everyone, avoiding junk foods. Is easy to say, but when the shops are nearby and it's easily accessible for the kids, it's difficult to, but things are there. So diversifying of the diets with the local food. Morning we are talking so much about millet, jowar, everything, but it should be included in the diet. And it's not only about then the diet, it should be agriculturally, it should be also viable. And it's not about agriculture, diet and everything. We have to see that we have to cater to this a huge population. Yeah. So anything, the green revolution started with the for catering to the population only. So how to feed the population first, not stepping aside the nutrition part. So that started and still it is continuing. You have to feed the population first, छोड़ो बाद में देखा जाएगा. Nutrition, so जो rich people had, they have started taking the nutrition part. Okay, but still the inherited thing has already been there in their genes, and that's thing continuing. So diversifying the diet, still the time is there. Diversifying diet is important for everyone. Continue focus on 1,000 days, the UNICEF 1,000 day of nourishment from the birth to 1,000 days. That should ensure adequate brain development, and that also include giving a minimum acceptable diet to the population. And I am telling this should be at least 100%. We can't think of that. We can't say that our kids are not having a minimum acceptable diet. So that thing should be uh, definitely there. Treat pregnancy as a special, that is also there. With the patrilineal society, this is, I think, with the more women empowerment and women autonomy, things are getting a little bit changed, because women are now taking things in their hand now. Okay, you are not treating me special, I will treat myself special. So that thing should be there now. Treat pregnancy as special. Nutritious food for women first, not last. So it that erode the cultural barrier. And special attention. Okay, in despite of this thing, if there is a low birth weight babies, how to tackle that? Sam ma'am children, tackling adequate the SBCC treatment, social behavior change communication treatment, that has started since long. The awareness programs are very important actually. Still now in rural areas, if somebody comes and tell you to do the thing, it's actually is good. They can listening to the thing. So the SBCC program jo hai in the rural areas, even in the urban areas, we are educated, but somebody is coming and telling you, okay ma'am, you have to do this, we are from the government, we are from the researcher, and you should do this one. We listen to them actually, still though we know with this thing, but somebody is telling and doing a canvassing. So that is an important thing to do, and I think those SBCC programs should continue every time. It's not that our population has more literacy now, it's not required. It's not, it is required every time. Follow up visits, follow up to these things are very important. You should follow up. It's not that ki ek ho gaya to you will keep aside the thing. No, it should be a continuous process. Follow up, follow up, follow up. It's a follow up, and this thing will ingrain in their mind. So that follow up thing is good, huh? Real time monitoring using technology. Now digital health, yeah, digital technology is so much in use every time. And I think everyone will accept that everything, in your mobile phone, in your hand, your health now is in your hand now, actually. You use it or not use it, that is different, but everything is monitored. You can do it, it's good. And even in rural areas, people are accepting that key, it's a good thing. So that real time monitoring and taking care of yourself using technology and this everything, and ensure IYCF practices, or this minimum acceptable diet, that is, from the NFHS third from 2015-16 until now 2024, that the MAD, that is minimum and acceptable diet, the percentage has not changed, it is still stagnant. So any program we are doing, we should focus on this only. First, basic, the first thing first, the basic first, do the basic first, so all ensure all children in preschool and school to ensure learning, diet, and avoid lifestyle issues. So this is their school education, so we don't have much data on that. So another thing, so this is a data. So how can you access the database? This is called healthnutritionindia.in. There is it is run by UNICEF and the IIT, I think Bombay. This can be click, and here you can. I don't know if this is not working. So if you click there, you will have a good graphs are there. You can have your own data set and combination and computation. You can check those things. Yeah. So one important thing about this data set, that see you in this data set we have data on food security as well, but it's is covered now. It's we can't we can use the data for that analysis purpose, so I have not used that. But we have really good data set, but that is not public, in public domain. That data set is cut off from this, that part of food security data is cut off, so we can't use that. And otherwise the data set is available. With the food security data, the data set can be available, anybody can access that one. Yeah. So it is, I have just given one example. As a you have more example, you have very small data set is also there, where you can have your own nutrition thing come. But most important, you should know what thing you want to understand from nutrition health programs. Yeah. So data set are available here and there. You have to check out and take out from there for research purpose. Actually, even also for policy, you need to have some evidence how to give in the policy level. You can't just talk in vain. So some data sets are there. It's not, see, from time immemorial, from the starting of the independence, from the since we got independence, we are so much bound with all other issues that health and nutrition has got in the last category. Still people are not in disease. Okay, you are okay, है ना. Disease हो गया, तो then it is okay, that okay, you have other programs, but still you are fine, you are not having any problems. So that thing was not taken care of otherwise, है ना. Now we are in a self-sufficiency era. We are all globalization, everything, everybody knows everything. So now people are getting more conscious. Oh, this thing is not happening with me, so I should take care of this one. So this thing is coming up now. So data sets is always important. Data talks. You, if you go somewhere and give your data, this is a finding, this is evidence, people will accept. And government is also doing lots of, but as I said, as a big survey on health is not there in India till now. This is there, this is only for 0 to 19 population with this information. We also require for other population, just like we are now having a burden of old age people, 60 plus. Our older population is now getting up more. now. Whom to help now, the younger population or the older population? They have their own issues. Our India is such a knit binding family culture. Is one dadi ji is not good, or whole population, whole family is not good. Everybody is taking killing, oh dadi ji ko ठीक करना. Similarly bacha is not good, so people are happy. So we have to ingrain both the things together. And since we are a huge population, till that is not an excuse to have a huge population and not to do anything. We have to take care, and people are getting literate and more efficient, more economically. We are happier now. Okay, we are happier with everything. So be happy and be happier with your health as well. Yeah, thank you so much for listening. I think it's all about data issues. Issues have been already discussed in the morning, so I'm just giving a glimpse of somewhere that the data is there. So anything you want to have any topic you want to have some data, where is the data we can get? I can information I can give you. But other the morning speakers are more good on telling the policy things. I'm not good in telling policy. I just know the general things.
Yes. So I'm Dr. Deepavali Bhattacharjee.
Yes.
I'm a faculty in Christ University. So recently I was dealing with this NSS data. Just to add to your point, ma'am, I think in NSS 75th round, they have incorporated a lot of health related variables.
Okay.
That is one thing. Another, regarding the older population, I think LASI data is sufficient for old population related to health. That is longitudinal aging survey. Yes. And one data set, that is IHDS, India Human Development Survey.
Yes.
That is jointly done by University of Maryland and
NCR.
Delhi. So there also you can get some health related variables, and also the qualitative health related variables, as in do people have confidence in medical institutions, do they have faith in hospitals. So such qualitative variables you can get in IHDS dataset.
Yes, that's thing. So as you said, that is fine. So so the LASI data and also the WHO SEDGE, study of global aging and adult, and that data set is also there. But as we said, that is not a very good representative, because it's only for 5-6 states they have covered. Otherwise you can analyze the data and have your own things. But yeah, they have a very detailed indicators on various health issues related to adult, from 60 plus, all type of health issues you name, and they are having there. Even you can analyze multimorbidity as well. Yeah, how much population is burdened with multimorbidity, but only for the 6 states. If you take this as a generalize that finding, that is fine. Otherwise it's only for the 6 states or 10 states, like this big small they have merged and taken this. But yeah, data is there for that reason. Anybody has used data, National Family Health Survey data? Yeah, any topic you have work on that? Okay, so for all over India or any particular state? Or a suffer. Okay, that's good. Consumption data, all that. 5 types of food items for men and women, entire population. Good. So only for NFHS 5 or a recent survey or other thing? Recent. Good. Any other use of data?
The stunting data in NFHS, it is for 1 to 59 months.
1 to 6, 0 to 59, yes.
0
Means
to
0 to
59,
5, 0 to 5 years.
So you have used 10 to
Oh, so I was talking about CNNS data.
That CNS data is recent, or it
At
is
2016-18.
So it is not recent. So how we will use that in our research? We need at least, because
so yeah, that's fine. Yeah, that's why I'm telling the survey data is been not
so
collected
how
recently.
to collect for the, if we are trying to do for more than 5
More age.
years, so how
It's
we will
not
do
there.
that?
It's not there available. We as an individual we can't do
And if
a
we are
census.
using NFHS 5, it is for 29,
Yeah.
21, and
Yeah.
this is for till 18, so that is not comparable.
Yeah,
Also,
and
if
also
you are using
NFHS
it.
we have 0 to 5, and
Yes.
here we have 0 to 19 years
Yes,
age.
so-
But again, it is for 5 years back data. We have, and again you have micronutrient deficiency data you don't have there, and they have some a little bit differences are there.
And for the nutrition, we have to go to some charts to calculate the nutrition from the consumption what is the consumption of the food items, if we
Yeah,
want the
that you have to
nutrient
make.
consumption.
That
What
can
is
be make. That can be made.
that
That
can,
is easier to do.
okay.
That is easier to do. You can find lot of papers based on that
This is data.
various food items and make an index. You can make an index
Yeah.
on that.
Okay.
Lots of paper are there. You can just check with NFHS 4 data, 5 data. There are lots of paper on that. Yeah.